So I'm Dr. Ashish, and I will be talking about airway management in thyroid cases. There may be some pictures or videos which I will be showing. The consent has been taken. So I will be covering only the main features related to pre-op considerations, intraoperative management, and post-operative management. So in thyroid diseases, we are concerned mainly of two things. One is functioning of the thyroid, that is, patient might be having hypothyroidism or hyperthyroidism. And other thing is the mechanical obstructions due to enlarged thyroid gland, which may lead to tracheal compression, deviation, or retrosternal extension. So while assessment, we should focus on any symptoms which are causing compression like dyspnea, dysphagia, hoarseness, which should alert us for the possibility of difficulty in managing the airway. So patient might lose the airway if we induce the patient due to loss of tone. So we all are aware of the routine tests which are done, including examination of thyroid. So I will not be going into those details. So virtual bronchoscopy is one thing which can be valuable in cases of Hughes thyroid malignancies, and retrosternal. So quickly we'll go to virtual bronchoscopy. So this is a non-invasive test which can be done by CT images, and these are volume rendered images which gives you a bronchoscopic image just like the actual bronchoscopy which we do. But the good part is that we do not need to insert the bronchoscope in patient's airway. So it is a non-invasive, it is safe, and it can be very useful for seeing the compression, any intratracheal infiltration, severity of compression, and so on. But the limitation is that we can't assess the dynamic changes in the airway diameters as we do in the actual bronchoscopy. But it can be a useful tool while deciding the airway management strategy. So another thing which can be done is 3D reconstruction and 4D reconstruction. This can be useful not only for airway management to decide what size tube, what type of airway management strategy you will plan. It also helps to decide the surgical planning. So if we combine it with 4D, then a dynamic airway assessment up to a certain extent is also possible. So while deciding airway management, we have to decide whether we want to go for awake or with sedation and general anesthesia. And if general anesthesia is chosen, whether we want to use muscle relaxant or without muscle relaxant. And then whether we want to go conventional with the direct laryngoscopy, video laryngoscope, or flexible optic bronchoscopy. In some cases, patient might not be able to lie down, so we have to decide whether we want to secure the airway in supine position or in sitting. So we have to weigh the risk and benefits of general anesthesia and awake. There are various techniques which are available for managing airway in thyroid cases. So it may be direct laryngoscopy, video laryngoscope, flexible fiber optic intubation, or hybrid technique. So the choice of technique will depend on the presence of compressive symptoms and worsening while lying down. So if patient doesn't have any compressive symptoms, which we discussed earlier, we can straightaway go with the general anesthesia with muscle relaxant and intubation with direct laryngoscopy or video laryngoscope. But if patient has a history of dyspnea, but that is not worsening on lying down, then we can choose general anesthesia with or without muscle relaxant, and intubation can be proceeded with the video laryngoscope or flexible fiber optic intubation. But if patient has dyspnea, which is worsening on lying down, or patient has a critical narrowing on the CT scan, Then awake intubation with flexible fiber optic or video laryngoscopy is advisable. But there are some cases where patient has severe dyspnea and he or she is not able even to lie down. Then we have to secure the airway even in sitting position. So I will be showing one case where we secured the airway in sitting position. So along with standard techniques of video laryngoscopy or fiber optic, we can combine these techniques, that is video assisted flexible intubation or combined technique or hybrid technique. And tracheostomy whenever needed can be considered at any stage. So depending on patient available resources and experience of the anesthesiologist, we have to formulate our plan A, B, and C. So if we have decided awake tracheal intubation, the awake tracheal intubation guidelines should be followed. A pre-intubation checklist should be followed, and all equipment should be kept ready. Oxygenation must be ensured throughout the procedure, and thorough topicalization should be done, and maximum lidocaine dose which can be used is 9 mg per kg. And number of attempts should be limited 3 + 1. So 3 attempts followed by 1 by experienced operator. And then tube placement must be confirmed with capnography before induction. So this is a case of 27-year female weighing 41 kgs. She had a neck swelling for 8 to 9 years, which was gradually increasing in size. She has a history of weight loss for 10 kgs in last 2 years. She was admitted in the our hospital for the surgery, but suddenly she developed dyspnea and she was not able to lie down. So she developed intratumoral bleed, due to which she suddenly decompensated. So we have secured the airway in sitting position, awake tracheal intubation in sitting position. So due to lack of time, I will be skipping the video. So once the tube was secured and it was confirmed doubly, one is with bronchoscope, another is with capnography, then patient was induced and placed in the supine position. So this is post-op period. Due to tracheomalacia, she was tracheostomized. This is another case of 55-year female with a large thyroid swelling for more than 30 years. She was having difficulty in breathing, which was progressively increasing in size. She used to sleep in the lateral position, and she has developed difficulty in swallowing for 6 months and recently developed change in voice for 2 months or so. So she has this much huge deviation or trachea and tracheal compression. So we intubated her with the hybrid technique or video assisted flexible intubation. Because of this huge thyroid, even with the flexible bronchoscope, it is difficult to negotiate because flexible bronchoscope will not be able to lift up the thyroid. So we couldn't record the video at that time, but to give you an idea of hybrid technique, this is another video. So in hybrid technique, we use 2 endoscopes. One is video laryngoscope and another is flexible bronchoscope. So once you visualize the epiglottis, the flexible bronchoscope is inserted through the glottis and you follow till the carina. And then endotracheal tube is inserted under vision to minimize the trauma. So this is the video laryngoscope, which is designed and patented by me. So extubation algorithm for major neck and upper surgeries has a very good algorithm. So to decide the risk, whether it's a low risk or high risk, we have to focus on the 3 things. One is the swelling in the airway, bleeding, and vocal cord paralysis. So if patient doesn't have these 3 things, patient falls into low risk category. And then if patient was not having difficult airway, we can extubate the patient after patient's efforts come and you have reversed. But if patient has high risk category, then after full reversal, after full reversal, patient's spontaneous breathing, we can extubate depending on whether patient was having any difficulty during intubation or not. If patient was not having any difficulty, we can extubate graded extubation, that is on the airway exchange catheter. And if patient was having any respiratory issues like OSA, then CPAP can be resumed. And in difficult cases, we can do cuff leak test. If cuff leak test is present, then it is indication that we can extubate if bleeding is not there. But if cuff leak test is not present, that is an indication whether patient might be having edema, or patient might be having nerve injury or tracheomalacia, or if there is significant swelling or active bleeding, we have to defer the extubation, and we have to re-evaluate after 24 hours, and we have to see again cuff leak, swelling and active bleeding and decide accordingly. So in post-op issues, patient might be developing tracheomalacia, especially after long standing compression, or patients having malignancy. So one must be ready for any emergency related to hematoma, and should be ready for hematoma evacuation, and should see for vocal cord palsy, and extubation should be planned with caution. In post-op care, patients should be nursed in 45-degree head-up position. Steroid can be given, which will help not only to decrease the chances of nausea, vomiting, will reduce the neuropraxia, and also help to reduce the analgesic requirement. Multimodal analgesia can be given, and ultrasound guided superficial cervical plexus block is a good choice to reduce the opioid consumption. Hypocalcemia is another concern after total thyroidectomy, and proactive planning should be done for patient safety. So these are the guidelines for Difficult Airway Society and British Society of Endocrinologists and Thyroid Surgeons for the close monitoring of the post-op thyroid patients. So we have to monitor closely for DSATs, that is any difficulty in swallowing, swelling, anxiety, difficulty in breathing and stridor. And if these are present, we should oxygenate, evaluate the patient and plan for evacuation. So these are the how to evacuate the hematoma. So this is simply scoop, that is skin exposure, cut sutures, open skin, open muscles and pack wound. So take home message is thorough clinical and radiological evaluation of airway is critical for success. Proper planning of airway management should be done. Should plan ABC and prioritize oxygen at every step. Video laryngoscope may be the first line for all intubations in case of thyroid. High frequency nasal oxygenation improves safety during intubation and extubation and decreases the chances of re-intubation in post-op. Front of neck access should be last resort, and whenever it is indicated, it should be opted. Cricothyroid membrane can be marked with the help of ultrasound, and prior information to senior person in case of help is needed is always better. And before extubation, especially in huge thyroid and malignancies, tracheomalacia and nerve injury should be excluded. An extubation plan is critical, and post-extubation care should be done in the high dependency unit or ICU. So thank you so much.
Dr. Ashish, thank you for that very crisp presentation.
Thank you.
We'll take questions at the end of the session. And while maybe there one little experience I'd like to share with you. I was doing a re-explorative parathyroidectomy, and it was quite deep in the tracheoesophageal groove. It was between the esophagus and the trachea. I had taken out, and I had to resect a little bit of the esophageal muscle. So when I was repairing the esophagus, the membranous trachea was in front of it, and my needle went through the membranous trachea into the balloon of the endotracheal tube. The patient desaturated, and then we had to take the needle out, take down the repair. On over a bougie, we had to take out the old endotracheal tube and then intubate the patient again.
Yeah.
She was in the ICU for about 3-4 days, and then uneventful recovery.
Even there are case reports where it was not detected, and while extubation, it was noticed that it has caught. So that is also reported. So that is a scary situation. Thank you for this.
Thank you very much. I now invite Professor Amit Agarwal. Every time we come to Lucknow, we find something new. So I'm curious to know what is new this time in the last 6 months.
So very good afternoon. At the outset, I'd like to thank my colleagues Gaurav, Anjali, Gyan, Sabha, and of course Abhishek for inviting me. Very happy to be here. I can recall the first postgraduate course that was held in '93 when Dr. Mishra conceptualized it, and I was there along with Sangeeta. And so it's a long way from since then. Now we are on the 16th postgraduate course. So next 10, 12 minutes, we'll talk about use of adjuncts. I think my job has been made easy by a previous talk by Dalapati, where an experienced surgeon can actually do a safe surgery. But let's see how technology can also help the experienced surgeon to refine his or her own surgery. So SGPGI has been my Karm Bhumi, and this is my new workplace. We all take the name of Cocker because he popularized modern thyroid surgery. And you'll be surprised to know that the capsular dissection that we do today was actually propounded by him. So not much has changed since the days of Cocker. But I'm very fond of our own heritage, and you'll be surprised to know that even in Shushruta Sahita, which is as old as 2000 years, even the use of surgery for goiter has been described, various types of goiter has been described. So if you're interested, you can go back and see that our heritage has been rich as far as thyroid surgery is concerned. Now, in last couple of decades, there has been a shift of paradigm. Mortality has decreased, but now the focus of the surgeons has shifted to a more, give a better cosmetic results by adopting robotic and endoscopic surgery, prevent recurrences by adopting total thyroidectomy rather than subtotal, and prevent complications, and two dreaded complications which all thyroid surgeons sitting here are aware. One is the injury to the recurrent angina nerve, and the other is injury to the parathyroid glands. And so let's see how we can minimize these complications. We can use a lot of adjuncts, but today I'm going to talk about only two adjuncts. One is neuromonitoring for recognizing the recurrent angina nerve, and the other is use of autofluorescence for recognizing the parathyroid glands. Coming to hypocalcemia, it's one of the most common complications, especially in a bilateral thyroid operation. And why is it detrimental? Because it's life-threatening, involves cost to the patient can have cardiac issues, increases your hospital stay, and reduces the quality of life. So as thyroid surgeons, we don't want our patients to be hypocalcemic. There are various intraoperative methods. Of course, when experienced surgeons, you visually identify the parathyroid gland. Previous historical techniques have been use of frozen section or a float or sink technique. And recently, utilizing the calcium levels and rapid PTH assay to predict whether the patient is going to develop hypocalcemia or not. The thing to realize is the more parathyroids you preserve, the less the chances of hypocalcemia. So as thyroid surgeons, it's imperative that we save all the 4 parathyroids. And so let's see how we can do that. And not only preserve the parathyroids, it's also important that we preserve the parathyroid glands with an intact vascular supply. Just anatomical preservation perhaps is not going to help. We need to have a good perfused parathyroid. The two commonly used techniques for identifying and preserving the parathyroids have been ICG angiography and recently the near-infrared autofluorescence. A word about ICG, we are all aware it's a very good molecule. When illuminated at 806 nanometer, it gives out a low energy laser you can identify with a camera. And then you can actually grade your parathyroids. If they are well perfused, it will be white. If they are partially perfused, they'll be gray and you give a score of 1. And if they are black, that means the blood supply has been conked off and you grade them as 0. Various equipments are available in the market. And this is one of the study which we did at SGPGI when I was here. And we really found that ICG is a good indicator or predictor of the absence of hypoparathyroidism after thyroidectomy. And in fact, is quite comparable to the rapid PTH assay, whether it's 20 minutes after surgery or 4 hours after surgery. So it's a valuable tool. But the problem with ICG is that it doesn't help you to identify the glands. It helps you to know whether the gland is perfused. But it's important that you first identify the gland. And here the importance of autofluorescence really comes in. Now, autofluorescence is actually all tissues autofluorescence. And it was found that the parathyroid tissues, the autofluorescence is 11 times higher than the surrounding tissues like the thyroid. Now, this property of the parathyroid was utilized in this equipment where it was seen that if it autofluoresces more than the thyroid, you can capture it on your monitor or by the camera. Now, there are two types of autofluorescence equipments. One is probe-based and one is the image-based. The probe-based is one of the commonest instruments used by the Medtronic, which was PTI. And this is actually a signal-based. And if the video works, then yeah. So it's just a model you see. You stimulate where you see is a likely parathyroid, and then you get a signal on the monitor. So these are signal-based, but you don't get any images on the monitor. Is there audio in this?
N ตัวพาราไทรอยด์ and confirmed by PTI the ratio more than
Hitting is the parathyroid.
the patient.
But the image-based autofluorescence techniques are better. And you get a nice image on the screen. The surgeons, it's very user-friendly. And one of the machines that we use is the made in India machine. This is the Airway machine. And we'll give you just preliminary experience for last 2 years. So this is the machine and this is the handheld scanner here. And you can do the different sequences. These machines can be used for fluorescence also. You can use in your sentinel lymph node biopsies in your breast cancers as well. So on the right side, you can see that bright image is the parathyroid. So this is the parathyroid. Here the intraoperative picture where I'm pointing. I'll show you a short video. So these are the two parathyroids on this side. So first you grossly visualize the parathyroids and then you perform. Now you can see on the monitor, these two bright dots are the parathyroids. So you are sure that the structures that you have saved is the well-perfused parathyroid. So this is an image-based system. So you can see on the right side, these are the two parathyroids here, and on the left side. So this is the intraoperative field after thyroidectomy, total thyroidectomy, and you have saved all the 4 parathyroids. So it really reassures the surgeon that the structures that you have preserved, that you thought were parathyroids, are actually parathyroid, and they are nicely visible on the monitor. So the patient is unlikely to develop a total thyroidectomy, yet it can develop a temporary hypocalcemia. This is an interesting case. We thought we were not sure out of these two structures which was the parathyroid and which we have retrieved from the specimen. And we did an autofluorescence. You see only one of the structures is autofluorescing. So we know that this is the parathyroid tissue and not the lymph node or the fat, and which we autotransplanted. So the other structure is not autofluorescing, only one structure is autofluorescing. So this is again, we have visually identified the parathyroid. You can see on the monitor, the parathyroid you can nicely see and you can save it nicely. So in 20 cases, mostly they were total thyroidectomy and some 4 cases they were with neck dissection. We could save 17 parathyroids in all patients. So all 4 parathyroids were saved in 17 patients, and whereas in 3 parathyroids were saved in other patients. Only out of 3 patients, out if you see on the right side of the sheet, only 3 patients had PTH which was low. Otherwise, all patients had normal or high PTH. So it correlated well with your autofluorescence. None of these patients developed hypocalcemia. On those patients where PTH was low, developed temporary hypocalcemia. So it really, reassures the surgeon. You can identify it before you damage the parathyroids. After that, you can again confirm that what you have saved is a nice, well-perfused parathyroid. A lot of meta-analysis and systemic reviews have been done, and all have confirmed that the autofluorescence is an excellent indicator for identifying the parathyroid glands during thyroid surgery. It does not have an important role in parathyroid surgery, so I'm not touching on that, but it has a definite role in thyroid surgery. So the advantages of autofluorescence over ICG is contrast-free, easy to use, Now moving on to the other adjunct, which is neuromonitoring. It's a very dreaded complication, and most of the consumer cases abroad are actually related to recurrent nerve injuries. The different causes, traction and cutting and thermal lesions, can all cause either complete or a partial paralysis of the recurrent laryngeal nerve. And it could be detected either immediate, early, or late. Why do we need neuromonitoring? Because there are a lot of anatomical variations, and we need to be aware of them. And intraoperatively, unless you have an endotracheal tube in place, neuromonitoring in place, you will not be able to do monitoring. So all cases actually should be monitored rather than only high risk or difficult cases. There is a lot of cases of invisible injury, as I mentioned, due to traction or thermal injury, and your IOM should be able to detect these lesions. So I'm sure yesterday you would have had a neuro monitoring workshop, so I'm not going into setup. These kind of a classical graph that you get on the monitor. I'm not going to the details, but avoid neuromuscular relaxant by the anesthetist. What are the advantages of the neuromonitoring? It helps in identification. It aids in nerve dissection. This is very important. It really saves time because early on you detect the nerve, and therefore your time is saved a lot. So it not only helps in identification, it aids in nerve dissection and saves a lot of time. And of course, it can predict post-operative vocal cord function identification at the nerve injury site. As I mentioned, in the high-risk situations, where you're doing a thyroid surgery for cancer, a large goiter, a Graves' disease, a reoperative surgery. But I am a proponent of the fact that you should do neuromonitoring in all settings because every thyroid is difficult. As Ashok Shah famously said, every thyroid is difficult, So you have to go with that mindset, have a neuromonitoring in place. If you get an anatomical variation, and if you have a neuromonitoring in place, you can very well save your nerves. There are a lot of systemic reviews which have shown that neuromonitoring is quite safe, and not only intermittent, you can also do a continuous neuromonitoring. So you see the graph here. At points, you will know where you are pulling the large goiter, so you can avoid the traction injuries also. So latest is continuous neuromonitoring, and the new equipment, you need not even place the electrode in the carotid sheath. So that advantage is there with NIM Vital. Can we have the audio? Yes, it's there. So this is the nice sound you get. I hope it plays, yeah. So these are a couple of cases where large goiters. This was a gentleman who came with the palsy, already had a palsy on one side. Can we have the audio? So this gentleman we operated under neuromonitoring, and this is the nerve on this side. So these kind of patients, nerve monitoring is very reassuring. Large goiters, you see the nerve is displaced, and you can help with the help of neuromonitor, you can identify the nerve. So as I mentioned, there are a lot of advantages. And if you see the last line, the low volume thyroid surgeons can have the advantage of using neuromonitoring. So not only experienced surgeons, but low volume surgeons can take the advantage. So recently I wrote a chapter for controversies, and there we found that the meta-analysis have all proven that the rate of nerve injury is much lower in use of neuromonitoring as compared to visual identifications. So there has been a controversy over the last 2 decades, but now studies have shown clearly that there is an advantage of neuromonitoring. Now, this is my last slide. Ashok Shah mentioned what should be the attributes of an ideal thyroid surgeon. I've slightly modified it. These are the attributes that I've dedicated my life to producing ideal thyroid surgeons. I'm happy that most of the top Indian thyroid surgeons are sitting here. So, one important attribute is that he should know how or to use the technology or an adjunct for minimizing the complications. There is no shame that all experienced surgeons can also refine the surgery with the use of neuromonitoring and autofluorescence. So I think a modern thyroid surgeon as of today should have a neuromonitor in the theater, should have an autofluorescence or an ICG equipment in the theater, so that you can really minimize and have an almost a zero rate of complications in your patients. And that is what, as an ideal thyroid surgeon, we should all aim for. So thank you very much for your kind attention, and thank you for inviting me. Thank you, chairpersons. Yeah.